everyone, and welcome to another edition of For the Health of It. I'm Lou Beccaria, your host. Today we'll be concentrating on the medical specialty of orthopedics, commonly known as the care of legs, knees, hips, and shoulders. For those of you, like me, who have had anything go wrong with one of these body parts, you know how important the specialty of orthopedics really is. For those of you who have been lucky enough not to have had an encounter with an injury to a leg or a knee or a hip or a shoulder, you'll find out from what we're going to talk about today some information that will be very helpful for you when and if you come face to face with a repair of one of these body parts. Here to inform us and educate us about orthopedics as a medical specialty is Dr. Karl Rosenfeld of the Phoenixville Hospital's Orthopedic Center. Dr. Rosenfeld, welcome to the show.
Thank you, sir.
Thanks for being with us.
My pleasure.
So, first of all, tell us just a little bit about your background.
I've been in the community, Phoenixville community since 1975. Some of the viewers may know me or have heard of me. I'm currently in practice now with some gentlemen whose names I will mention. And the reason I'm here, I'm a Baltimore native, is I trained at the University of Pennsylvania. I like the area. And except for 2 years of the Army in 1973 to 1975, I've been here ever since. I'm in practice with Michael Messina, James Schaefer, and two other hand surgeons. And together we are very excited about the growth of our orthopedic center.
So tell us about the Orthopedic Center. What makes up the Orthopedic Center? Do you have a team of medical professionals other than orthopedic surgeons?
We have Dr. Kowalski, who will see, like I do, stuff that comes off the street in general in orthopedics. We're associated with physical therapy. We have x-ray. And we also have the advantages of the Phoenixville Hospital and their satellites for whatever radiographic studies, including MRI, that we may need.
Mm-hmm. And are you what is known as a general orthopedic surgeon,
Yeah.
or are there other subsets of that?
The answer is yes. I'm what's called a generalist. Maybe some would call me a dinosaur. One of the reasons I chose orthopedics as a medical student, and even before, was I love sports, mm-hmm. and I wanted all parts of the body, both sexes and all ages. One of the things I feared was boredom in whatever I chose in life. So when I go to the office every day, I might see a kid, and as a grandfather, I love children. I might see, I would call older people, although I'm now an older person, and middle-aged people, athletes, weekend warriors. I've seen professional athletes, college athletes, high school athletes. That's a generalist. We take all comers. Now, especially, which has evolved over the last 10 or 15 years, are those men and women who, although they might see things outside their specialty, are trying to confine their expertise to one area. Michael Messina, for instance, whom we're delighted to have. Michael's beginning his third year with us, and he's Harvard trained in shoulder, doesn't confine himself to the shoulder, but would like to do just shoulder. So we've pretty much dovetailed most of our shoulder problems, particularly replacements, to Michael. James Schaefer, he likes to do joint replacements. He's right now our joint guy, and he does most of our knees and hips. So there are doctors now, orthopedists around the area and country, who confine themselves to one part of the body.
I understand that you have a certificate qualification, your advanced certification.
Our hospital has become advanced certified in joint replacement. That's a relatively new event. And the way you get that is surveyors come in, look at your work, look at your statistics, look at your educational program, look at your complication rate, look at how fast people are getting out of the hospital, making sure they don't have to come back to your hospital for a problem that's occurred. And if you pass these criteria and others, then you're deemed certified and can hold the banner up and say, we do a pretty good job with joints.
Yeah. Is there a recertification process every couple of years for this?
I'm unaware of that. I'm guessing, but I don't know for sure.
Yeah,
I wouldn't want to
most
answer
certification
that.
processes
Yes, sir.
do have that. Dr. Rosenfeld, what is the most difficult part about being an orthopedic surgeon? Is it the complexity of the body parts that you deal with, or is it the kind of patients that you tend to deal with, particularly the athletes? What is it?
It's an interesting question, and one that I'm not going to be able to answer easily. Every day when I go to the office, and I've been doing this for a long time, I try to remind myself, these people are not coming to see me because they've heard about me, but they're coming because they're in trouble. They have a problem. It's affecting their work, it's affecting their relationship at home, it's affecting their ability to play sports, it's affecting their ability to walk. And I have to remember when I walk in that room that I'm there to try to render an improvement and comfort to these people. So what's the most challenging thing? Every patient's a challenge. Every problem is a challenge. Newer doctors, of which I once was, come into the office and say, gee, I wonder what I can fix in the operating room. Because we're trained to be surgeons, and we want to exemplify our art. We want to show the community how great we are in surgery. And so when I was younger, I think that's how I used to think. As time evolved, and certainly now, I approach people with a different idea. How is this problem affecting this patient? Is it killing them financially? Can they afford to take time off for surgery? How does it involve their parentalhood? How does it evolve? How does it affect their weekend status? And so when you do that, surgery is probably the last thing you want to offer them unless it's absolutely necessary. So an easy way to answer your difficult question is every orthopedic problem is challenging and every orthopedic problem can be difficult.
Okay. All right, we're going to take a break for Pay the Bills, Doctor.
Okay.
We're talking with Dr. Karl Rosenfeld of the Orthopedic Center of Phoenixville Hospital Tower Health. When we come back, we'll hear more about the specialty of orthopedics from Dr. Rosenfeld. Please stay with us. We'll be right back. Welcome back, everyone, to For the Health of It. For those of you who are just tuning in, we have the pleasure today of talking with Dr. Karl Rosenfeld of the Orthopedic Center of Phoenixville Hospital Tower Health. And we're talking about the specialty and the various aspects of it, and also about his team. So, Dr. Rosenfeld, for those who are just tuning in, could you tell us again about who are the members of your orthopedic team at the Orthopedic Center?
I'm Karl Rosenfeld. I'm the elder statesman of the group. Michael Messina is our shoulder guy, although he sees trauma and other problems. James Schaefer is our total hip and total knee replacement guy, although he also does our trauma and sees general patients. Dr. Evan Kowalski is an orthopedist whose experience almost equals mine, and he now just sees office patients, but he has a heavy practice. He's very bright, very experienced, and he knows what to do with the patients, and he knows when conservative management's failed and whom to send them to for surgery. We're also blessed with two hand surgeons. Dr. John Rosenfeld, no relation, interestingly. People always ask me if he's my son. He's not. And then Dr. Greg Gershowitz, who joined us a couple years ago from Chicago. So we have two hand surgeons aligned with in our office.
Okay, that's a pretty big team.
We're getting bigger, and we're still looking for talent.
Okay. All right, I'd like to ask you, Dr. Rosenfeld, tell us about the art of medicine. What does that mean, the art of medicine?
When I was in medical school, they began to talk about the art of medicine. I don't think I appreciate it as well as I have in practice. And this is what, to me, the art of medicine is. A person comes to you, and I'm going to use an MRI of the knee as a very typical example of what I'm trying to demonstrate. Person comes in, say middle-aged person or older, they have pain in their knee, and their MRI shows a torn meniscus. And they've been told by the family doctor or another orthopedist, you have to have surgery, because the MRI demonstrates a torn meniscus. You have to talk to those people and find out what is your complaint. As I explain to patients, and they probably think I'm being facetious, I don't talk to x-rays. I don't operate on x-rays. I talk to people. I have to hear certain symptoms. And again, if we're talking a torn meniscus, I have to hear locking or giving way, or pain in a specific site that hasn't responded to conservative management. However, I'm almost embarrassed as a specialist to say that throughout my community and communities throughout the United States, people get operated on every day because the x-ray is positive, but it is not the cause of the pain in their knee. So the art of medicine is it's like a chef. We look at the x-ray, we look at the patient, we listen to the story, which is very important. It's called history taking. We put them all together and we mix them up, we come up with a diagnosis, and that's the art of medicine.
So continuing with this further, Dr. Rosenfeld, if the X-ray or MRI shows that there is a torn meniscus, and you feel like surgery is not the answer.
That's not the cause of their pain, is what I try
Yeah.
to convince them. It's arthritis.
Oh, okay.
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 And that is a
Even
crap.
if there's a tear.
Even if there's a tear, because a middle-aged person or older who has an arthritic knee will more than likely have a torn meniscus, because the knee arthritis has caused irregular surfaces. Everybody calls bone on bone. And because of those irregular surfaces, there's a wearing down of the meniscus. So more than likely, the MRI is going to show a torn meniscus. You go in and take out the meniscal tear, a couple things happen. One, the surgeon makes a buck. Two, the patient thinks for a couple months they're better off. And three, after a couple months, they're not only not better, but commonly worse, heading for a total knee.
The reason why I'm laughing is because I lived that.
You went through that?
When I was 19 years old, I tore the meniscus in my knee.
Well, that's
playing
different
sports.
at 19. We're not talking a 19-year-old athlete. We're talking people our age.
Yeah, but back then, this was 1964, they just took the whole meniscus out.
Can I comment to that?
So let me just finish.
Go ahead.
I refer to that as the Neanderthal time of orthopedics. So for 50 years, until 4 years ago, I actually had bone on bone, and it got worse and worse and worse. So tell us about the progress then, using that as a case study, the progress of orthopedics from that time where they noticed that it was a tear, take the whole thing out.
Lou, your story cuts me to the quick, and I'll tell you why. I trained at Penn, which was and still is a very prestigious university. With my chairman was Edgar Ralston. He was a Quaker, may he rest in peace, most conservative guy in the world. I loved him. He was like a father figure. We were taught, and I did my residency, I'm almost embarrassed to say this because no one will come see me, 69 to 73. We were taught the proper treatment for a torn meniscus is to take the whole meniscus out. And to do less was malpractice.
Wow.
Right. So using you as an example, you can imagine how many total knees we created. You may or may not have this as a question to come to, but I'd like to refer to it now. People have often asked me, Dr. Rosenfeld, in your time, what is the greatest advancement in your specialty that you've seen? And by far and away, it's the arthroscope, invented by a guy named Watanabe. I think it was Japanese. And what that's allowed us to do, and I came up in your era pre-scope time when there was no arthroscope. There were no MRIs. We used arthrograms, which were not great. And so we used our clinical judgment. We went in, and the problem was we were trained to take it out because you couldn't see the back of the meniscus until you had the damn thing almost completely gone. So how many normal menisci did we take out? Plenty. How many total knees did we create? Plenty. But the scope has now allowed us to put 2 and sometimes 3 tiny holes in the knee, to look in corners that you can see better than if the knee is open. And most importantly, either repair, meaning stitch if it's a young person like you were, or debride the meniscal tear, which means cut out the part that's torn without taking out the whole meniscus. It's done everybody knows, as an outpatient. I'm not going to say how fast I do it because it sounds like I rush, but it's pretty quick once you've done several thousand. And every orthopedist in his or her training has learned how to do this. Scope can be used for other joints, but again, it's kept people out of the hospital, they recover more quickly, and most athletes are back within 6 weeks to their sport.
Yeah, yeah.
It's an amazing invention.
In my case, it was like 6 months.
Correct,
So,
correct.
Yeah. So what advances beyond the orthoscope? Are there other advances in orthopedic surgery that have come about in the last 10, 15, 20 years, that whether it's in the pre-op part or the post-op part?
Well, everybody knows about a joint replacement. Who hasn't heard about a knee replacement? But that's been going on for longer than 15 or 20 years. The first hip replacement was done back in the 70s, and the father of hip replacement is a guy named Mr., because in England the surgeons called Mr. It's insulting to call him or her doctor.
Really?
Mr. John Charnley, yeah. And he basically is the father of hip replacements, although I Googled this once. I think the Chinese were doing hips back in the 16th century. Yeah, you can check that. Anyhow, so he started the business. It then came to America. And it's evolved, as everything has, to the point where today we've got it down to what we think is a fine art. And 20 years from now, we'll look back and say, they did it that way. Our incisions are smaller. We're now using computers before the surgery to help us find the right size and angle to put them in. One of the questions I saw that you may get to is robotic surgery. It's a big deal now, the robot. In orthopedics, it's still embryonic. Some doctors are starting to do what they call robotic-assisted joint replacement, meaning the incision's small, they put the robot, which means some small instruments in some holes, but it's not state-of-the-art yet. Mm-hmm. Now, of course, when arthroscopic surgery came out, we said that wasn't state-of-the-art, and of course today it is. So everything I say today
is relative.
And if anybody looks at this 10 or 15 years from now, they may laugh at what I'm saying.
Yeah. Before we break for another commercial, I'd just like to cover this. In the introduction, we talked about different parts of the body, the knee, the hip, the shoulder. In doing this surgery, are any one of those parts of body more difficult than any others?
Yeah, well, let's talk about trauma. Car accident, fall out of a window, that kind of thing. The pelvis, by far and away, is the most difficult area to fix. And thank God there are people now who do nothing but that. Again, when I was younger, almost every pelvic fracture was put to rest and we treated it non-operatively because our surgery wasn't very good. Now with plates and screws and great training, pelvic fractures are fixed. So I think a difficult pelvic fracture, to my estimation, is probably the most difficult operation to do. Spinal surgery can be very challenging, scoliosis, particularly in adult, failed backs where they have to go and infuse, put screws in, metal in. So those are the things that I think are the most challenging.
All right. We're going to take a break, Doctor, for a commercial again, and when we come back, I'd like to delve a little bit more into the why about those. We're talking with Dr. Karl Rosenfeld about orthopedic surgery at the Orthopedic Center at the Phoenixville Hospital Tower Health. We're going to take a break, folks, for a commercial, and we'll be right back, so please stay with us. Welcome back, everyone, to For the Health of It. We have the pleasure today, for those of you who are just tuning in, to be talking to Dr. Karl Rosenfeld, who is an orthopedic surgeon at the Phoenixville Hospital Tower Health. When we left, we were talking about the difficulty of the different parts of the body that you work with, and you were talking what happens, but could you tell us why they are more difficult? Different ones are more difficult.
Well, starting off with the pelvis, the anatomy is more challenging because you're going through a large network of vessels and nerves. Primum nocere, first do no harm, which we're all taught in medical school, first do no harm. You don't want to make the patient worse. So when you go into the area of the pelvis to fix a pelvic fracture and or an associated hip fracture, you're going around some potentially dangerous structures if you harm them, the nerves and the vessels. Almost always there's a lot of bleeding there. The bone itself bleeds a lot. People don't think of that. Does bone bleed? Yeah, bone bleeds. So you're going to get blood loss, potential for what we call neurovascular problems. And again, people who know how to do this well are now using plates and screws to stably fix these areas so when the patient is out of bed and starts to move about, it'll hold together. Mm-hmm. As far as the spine's concerned, again, you're working next to the spinal cord. And paralysis or nerve damage, incomplete paralysis, is always a concern. So again, I think the thing that most determines, in my opinion, the difficulty of an operation is its proximity to things that you don't want to harm. For instance, when you scope a knee, there aren't that many things that potentially could go wrong, although anything can go wrong anytime. You pull a tooth, people can die. Right. But most arthroscopic procedures, for instance, do not carry the potential for harm as these open procedures, spine and pelvis that I've talked about. Yeah,
because there's more complications in terms of
more complications.
Nerves, blood vessels and things.
Correct.
Does the Orthopedic Center, Doctor, at Phoenixville Hospital offer any seminars, educational means for people to become more educated about orthopedics and about how to keep their body healthy so that they don't need your services? Sorry about that.
No, that's fine. And I'm happy to speak about being a gym rat, of which I am one if you want. But the answer is yes, we do have seminars. And if they'll just Google Phoenixville Hospital, the website is there. And they can look at the website or even call the hospital and ask for information about seminars. Phoenixville is very good about periodically giving lectures, having seminars for the community about the things that you've talked about. And also, our total joint program also invites people in for a pre-operative educational, where they talk about how to cleanse themselves before the surgery, what antibiotics they may need before the surgery, having their teeth checked before the surgery, things like that.
Wow, great. Okay, well, it's nice to know that there's that kind of service available. One other question I'd like to ask you is, what is considered state-of-the-art post-operative care? You know, we've talked a lot about the surgeries, but what happens afterwards?
That's a great question. The reason is, oftentimes people say that's a great question. It's not a great question. This is a great question because the biggest thing that we're doing now at Phoenixville, and Phoenixville is not unique, is light anesthesia. In other words, we're using less anesthesia today for surgeries. We're using more non-gaseous, non-IV drugs to try to make the patient recover more quickly, to get him out of the hospital more quickly, to cut down on nausea, which everybody worries about after surgery. So light anesthesia is becoming an in-term for operations that are done as an outpatient. And even inpatients now, they've changed their approach. One thing that I find fascinating, because when I was younger, NPO after before the night of the operation, NPO, which most people know means nothing per mouth. In other words, after midnight, you couldn't have anything or you got sent home. Now they're allowing people to have certain substances up until the time of surgery because they're finding out, especially fluids, that the people do better during surgery having had some liquids or other substances, which I still find amazing. One of the reasons I'm not going to retire yet, I still love what I do. And one of the reasons I love what I do, besides taking care of people, which is very exciting to me, I'm still learning. Mm-hmm. I'm still learning stuff that if I weren't a doctor, I don't think I would know.
Yeah, okay. One final question before we have to wrap this up. What are the plans? If you had a crystal ball, what are your plans for the Orthopedic Center for the next 5 or 10 years? What would you like to see happen? And what kind of research is going on to improve the field of orthopedic surgery?
Tower, if you're listening, here's what I would like. As I said, we're bringing in other doctors. We're going to bring in another joint replacement person, not just versed with standard joint replacements, which our Dr. Schaefer is, but can handle the complications of a joint replacement, infection, fracture, and cases that someone might want to send to the university that we want at Phoenixville Hospital. So, and that's coming. We should have that person here just about by August or September. What's not here yet, and which I'm screaming for, is a spine surgeon. We know whom to send for our spine work, but we would like to keep it all at Phoenixville. So we're in the market looking for a spine doctor. That would be great. As time evolves in the next 5 or 10 years, I know we're going to grow. We'll probably have someone who just does sports. I don't think we'll have a pediatric orthopedist because none of the general hospitals have enough pediatric action, and we're fortunate to have things like CHOP, Newmars at DuPont and St. Chris. They're all excellent places. So spine surgeon, maybe a sports surgeon, and also maybe a foot and ankle guy, although we're also happy to have in our group an outstanding podiatrist who does a lot of work for us.
Yeah, well, that's great. Well, Doctor, thanks very much for taking time out of your practice. It's been very informative, interesting, and I got to talk a little bit about my own situation.
Which is always fun.
So, thanks very much.
Thanks for having me.
Well, that'll about do it for today's show, folks. We hope that you've enjoyed the show and have found it informative. If so, we've achieved our mission. Once again, I'd like to thank Dr. Rosenfeld for being our guest and for sharing his expertise about orthopedics with us. Until next time, everyone, I'm Lou Beccaria. It's my pleasure to be your host. And remember, everyone, if you're healthy, you're wealthy. We'll see you next time.